Part 1, Understanding the Problem. Number 1. Patient arrives at the clinic. We have a 17-year-old male patient. He comes to the dental clinic because he has noticed a problem with one of his teeth. His main concern is that a filling has fallen out from a lower right back tooth. Since the filling came out, the tooth feels rough. A sharp edge is present. The sharp edge is irritating his tongue. He does not report severe pain at the moment. Number 2. History of the problem. When we ask more questions, the patient tells us that about 1 year ago he had pain in the same tooth. The pain occurred when eating hot food and cold food. This type of pain usually means that the decay had reached close to the pulp. At that time, a filling was placed in the tooth. However, the patient did not continue treatment. He did not attend follow-up appointments. Later, he moved to another place and did not register with another dentist. Because treatment was not completed, the disease process continued slowly. Over time, the tooth became weaker. Eventually, the filling fell out. Now the tooth surface is exposed and feels sharp. Even though the patient does not feel pain now, the previous history suggests that the decay was deep and the pulp may have been affected. Number 3. Medical history. The patient is medically fit and healthy. There are no medical conditions affecting dental treatment. Number 4. Extraoral examination. The patient's face is examined. There is no swelling. There is no facial asymmetry. The lymph nodes in the neck are not enlarged. Jaw movement is normal. These findings show that the infection has not spread beyond the tooth area. Number 5. Intraoral examination. The mouth is examined carefully. The oral tissues appear healthy. Oral hygiene is reasonably good. Mild gingivitis is present. This means there is slight inflammation of the gums due to plaque. No calculus deposits are seen. Periodontal probing depths are normal. This means the supporting tissues of the teeth are healthy. Number 6. Examination of teeth. The lower right first molar shows extensive damage due to decay. A large cavity is present. A significant amount of tooth structure has been lost. On the gum near this tooth, a small opening is present. This opening is called a sinus tract. A sinus tract is a pathway that allows infection to drain from the root of the tooth into the mouth. The presence of a sinus tract suggests that infection has reached the root area. The lower right second molar shows a small cavity on the biting surface. No teeth are missing. Wisdom teeth are not yet visible. More than one tooth shows decay. This indicates active caries. Number 7. Pulp vitality testing. Pulp vitality testing is carried out to check whether the nerve inside the tooth is alive. Cold test or electric pulp test may be used. The lower right first molar does not respond to testing. This indicates that the pulp is non-vital. Other teeth respond normally. This shows that the infection is related to the lower right first molar. Number 8. Radiographic examination. Radiographs are taken to assess the extent of decay and infection. Number 8.1. Bitewing radiographs. Bitewing radiographs show several cavities affecting the chewing surfaces of molars. No decay is seen between teeth. This pattern suggests that the disease mainly affects occlusal surfaces. Number 8.2. Periapical radiograph of the lower right first molar. The radiograph shows that the cavity has reached the pulp. A dark area is present around the root tips. This dark area indicates infection in the bone. Loss of lamina dura is seen. Bone changes are present around the roots. The tooth has moved slightly forward. The tooth is tilted. The normal contact with the adjacent tooth is lost. Loss of contact may allow food to become trapped. Number 8.3. Sinus tracing. A gutta-percha point may be gently inserted into the sinus tract. A radiograph is taken. The gutta-percha shows the pathway of infection. This confirms the source of infection. Number 8.4. Panoramic radiograph. A panoramic radiograph may be taken to examine the entire dentition. It helps assess developing wisdom teeth and general dental condition. Number 9. Diagnosis. The lower right first molar is non-vital. Infection is present around the root. A sinus tract is present. Other molars show occlusal caries. Overall, the patient shows high caries activity. HALA Part 2. Why the disease developed. Why we need to look at the cause. After examining this patient, we know that he does not have decay in just one tooth. He has one severely damaged lower right first molar, another occlusal cavity in the lower right second molar, multiple occlusal carious lesions seen on the bite wings. So this is not a single tooth problem. This is a high caries activity pattern. Because of that, we must find out why the disease is happening. That is why the next step in the case is diet analysis. Number 2, how the diet was recorded. The patient was asked to complete a diet sheet for 4 consecutive days. This is important. It was not just one random day. It was 4 days in a row so that the record would be more reliable and would show the patient's usual habit. The 4 days included 2 weekdays, 2 weekend days. This is also important because eating habits are often different on working days and leisure days. The diary recorded the time, the food or drink taken, the amount. This gives a clear picture of how often the teeth are exposed to sugar during normal daily life. Number 3, what the diet sheet showed. When the diet sheet is reviewed, the main finding is that the patient is taking sugary foods and drinks many times throughout the day. The chart includes items such as tea with sugar, chocolate, biscuits, cake, cola or fizzy drinks. These are not only taken with main meals, they are also taken between meals. That means the mouth is being exposed to sugar again and again from morning until evening. So the important problem is not just that he eats sugar. The important problem is that he eats or drinks it frequently. Number 4, why the frequency matters in this case. Each time the patient takes a sugary food or drink, plaque bacteria use that sugar and produce acid. That acid attacks the tooth surface. After one acid attack, saliva can help the mouth recover. But in this patient, sugar is taken again before the mouth has enough time to recover fully. So instead of a few isolated acid attacks, he is having repeated acid challenges throughout the day. That repeated pattern explains why. Several molars have occlusal caries. The disease is active. One tooth has progressed much further than the others. This case clearly shows that frequency of sugar intake is the main dietary problem. Number 5. Importance of snacks between meals. Another important detail in this case is that many sugary items are taken as snacks between meals. This is more harmful than taking sugar only with meals. Items like chocolate, biscuits, cake are especially relevant because they may stay on the tooth surface longer. So in this patient, the problem is not only sugary meals, the problem is repeated sugary snacking between meals. That keeps exposing the teeth to fresh acid attacks. Number 6, role of sugary drinks. The diet sheet also shows sweet drinks, such as tea with sugar, cola or fizzy drinks. This matters because drinks can be taken several times a day and they may be consumed slowly. That means the teeth may be exposed to sugar for a prolonged period. So in this patient, the drinks are also contributing to the high caries rate. Number 7, why this fits the caries pattern we saw there. The radiograph showed mainly occlusal caries in molars and no proximal caries. That pattern fits well with the diet history. Molars have pits and fissures where food and plaque collect easily. If sugary food and drinks are taken frequently, those areas are repeatedly exposed to acid. So the diet sheet helps explain why the caries pattern is mainly on the chewing surfaces of molars. Number 8, main conclusion from the diet analysis. The diet analysis shows that this patient has a high frequency of fermentable carbohydrate intake over 4 consecutive days, including 2 weekdays and 2 weekend days. The important dietary problem is repeated sugar intake, sugary snacks between meals, sugary drinks taken several times a day. This repeated exposure explains the high caries activity seen in the mouth. Number 1, overall treatment idea. This patient does not have only one tooth problem. He has one tooth with infection, lower right first molar, other teeth with active caries, an eating pattern that is causing ongoing decay. So treatment cannot start with permanent fillings immediately. If we place permanent restorations while the disease is still active, new cavities may continue to develop. Therefore, treatment must follow a sequence. First, we control the disease. Then we place definitive restorations. Number 2, immediate phase, treating the infected tooth. The first priority is the lower right first molar. This tooth has extensive caries, non-vital pulp, periapical infection, sinus tract. This tooth is the source of infection and must be treated first. Caries is removed from the tooth. An access cavity is prepared so that the root canal system can be reached. This allows drainage of infection. The canals are cleaned. An irrigating solution such as sodium hypochlorite is used to disinfect the root canal system. After cleaning, a temporary restoration is placed. This temporary restoration seals the tooth and prevents contamination from saliva and bacteria. This step is important because the infection must be controlled, the tooth structure must be preserved, further breakdown must be prevented, the tooth must remain restorable, the tooth must remain functional in the mouth. At this stage, root canal treatment is started but not yet completed. The aim is to stabilize the tooth. Number 3, stabilization phase. Managing other carious teeth. After dealing with the infected tooth, the other carious teeth are treated. Caries is removed from the affected molars. Temporary restorations are placed. The purpose of temporary restorations is to stop further progression of decay, to reduce bacterial activity, to protect the pulp, to make the mouth stable before definitive treatment. This step is important because the patient currently has active disease. The disease must be controlled before placing permanent restorations. Number 4, preventive phase, addressing the cause. Since the diet analysis shows frequent sugar intake, prevention is essential. Diet advice is given to the patient. The patient is advised to reduce how often sugar is taken, avoid frequent snacking, limit sugary foods to meal times, avoid sipping sugary drinks repeatedly, avoid sugar intake late in the evening, choose safer snacks when possible. The aim is to reduce repeated acid exposure to teeth. Fluoride is also recommended. Fluoride toothpaste should be used regularly. Fluoride helps protect enamel and reduce the risk of further decay. Oral hygiene instructions are reinforced. Even though oral hygiene is reasonable, plaque control is still important. Preventive measures begin early and continue throughout treatment. Number 5, temporary restorative materials used in this phase. Temporary materials are used to stabilize the teeth before definitive restorations are placed. Materials mentioned in this case include zinc oxide eugenol, self-setting zinc oxide materials such as Cavit polycarboxylate cement, glass ionomer cement. Glass ionomer cement is particularly useful in this patient because it releases fluoride and helps protect against further caries. Temporary restorations allow the dentist to monitor whether the disease is becoming controlled. Number 6, removal of caries in vital teeth. When removing caries from teeth that still have vital pulp, care is taken not to expose the pulp unnecessarily. Soft infected dentine must be removed. Very soft dentine must be removed. In very deep cavities, dentine close to the pulp may sometimes be preserved to avoid pulp exposure. This helps maintain pulp vitality. Number 7, definitive treatment phase. After disease activity is reduced and preventive measures are in place, permanent restorations can be placed. Number 7.1, definitive treatment of lower right first molar root canal treatment is completed. After root canal treatment, a large amount of tooth structure is already missing. Because the tooth is weakened, a core buildup is placed to rebuild the lost tooth structure. If there is insufficient natural tooth structure remaining, a post may be placed inside the root canal to retain the core. Because the marginal ridges and cusps are weakened, the tooth may require cuspal coverage. A crown may be placed to protect the tooth from fracture. The crown helps restore strength and function. Number 7.2, definitive treatment of other molars. Molars with occlusal caries are restored with permanent restorations. Materials may include composite restoration, glass ionomer restoration. Glass ionomer is useful because it releases fluoride and helps reduce risk of recurrent caries. The choice of material depends on the size of the cavity and the amount of remaining tooth structure. Number 8, review and maintenance. After treatment is completed, regular follow-up visits are required. At review appointments, the dentist checks whether new caries have developed, whether restorations are functioning properly, whether the patient has changed diet habits, whether oral hygiene is maintained. Regular review helps prevent recurrence of disease. Number 1, why did the lower right first molar become so badly damaged? In this patient, the previous treatment was not completed. Because of that, the disease continued progressing. Over time, more tooth structure was destroyed. Eventually, the filling failed and the tooth became severely broken down. Number 2, why did the disease progress without pain? Earlier, the patient had sensitivity to hot and cold. Later, the patient did not feel pain. This change suggests that the pulp gradually lost vitality. When the pulp becomes necrotic, The nerve inside the tooth no longer responds. Pain may reduce or disappear. However, infection may continue inside the tooth. Bacteria inside the root canal can spread to the surrounding bone. In this patient, infection reached the root tip and caused periapical inflammation. Number 3. Why did a sinus tract form? When infection reaches the bone around the root, inflammatory fluid or pus may form. Pressure develops inside the bone. The body tries to reduce this pressure. A pathway forms through bone and gum tissue. This pathway allows infection to drain into the mouth. This drainage pathway appears as a sinus tract. Because infection is draining, pressure is reduced. That is why the patient does not currently feel severe pain. The presence of a sinus usually indicates a long-standing infection. Number 4. Importance of contact between teeth. The radiograph shows that the lower right first molar has tilted slightly forward. Because of this movement, the normal contact with the adjacent tooth has been lost. Normally, teeth touch each other at a small contact point. This contact point is important because it prevents food from getting trapped between teeth, maintains tooth position, protects the gum between teeth. When contact is lost, food may become trapped, cleaning becomes more difficult, plaque may accumulate, risk of further decay, increases risk of gum inflammation increases. Flat contacts are less effective than normal point contacts. This is important for long-term maintenance of the restored tooth. Extraction may be a more suitable option than extensive RCT and crown because the tooth is grossly carious with extensive loss of tooth structure. The pulp is non-vital and periapical infection is present. The tooth has been previously heavily restored and is structurally weakened. The mesial marginal ridge is lost, reducing resistance to fracture. The tooth has drifted mesially and tilted, making ideal restoration difficult. Complex treatment is required, RCT plus core buildup plus crown. The long-term prognosis is uncertain. There is increased risk of fracture or recurrent caries even after treatment. However, if the patient wishes to save the tooth at any cost, orthodontic uprighting may be considered because the tooth has tilted mesially due to loss of tooth structure. The proximal contact with the adjacent tooth is compromised. Poor contact can lead to food impaction. Food impaction increases the risk of caries and periodontal problems. Uprighting improves contact relationship. Improved contact supports the long-term longevity of the crown. Number 9. Why glass ionomer cement is useful in this patient. Glass ionomer cement has some advantages in high caries risk patients. It bonds chemically to tooth structure. It releases fluoride. Fluoride helps reduce risk of further decay. It provides a good seal against bacteria. Because this patient has active caries, glass ionomer cement can help protect the tooth. Number 10. Why zinc oxide eugenol is used as temporary material. Zinc oxide eugenol is often used as a temporary restoration. It has antibacterial properties. It is easy to place. It is easy to remove when further treatment is needed. It provides short-term protection for the tooth. However, it is not strong enough for long-term use in areas with heavy chewing forces.